webinar called COVID-19 and Data Collection Resources for Your Community. My name is Joy Moses. I am the director of the Homelessness Research Institute at the National Alliance to End Homelessness, and I'm going to moderate today's session. We have a great panel today that I want to introduce to you. Before I do that though, I will mention a couple of housekeeping issues. The first one is that everybody who is participating in the session today is on mute. If you have a question that you would like to ask, you can add that question to the Zoom Q&A box, and we'll be monitoring and make sure to insert some of your questions into the conversation. We also want to remind you that this is a part of a series that we have developed, and we encourage you to continue following the series as we add new chapters. And if you miss one, you can go to our website and make sure that you can play the recording. Finally, we have recently instituted a online Ending Homelessness Forum. Through the link up on my screen, you can go ahead and sign up for that and participate in all sorts of conversations about COVID-19 and other issues. So now I will introduce our panel. Fran Ledger is joining us from the U.S. Department of Housing and Urban Development. Following her in the lineup will be Dan Treglia. He is a professor at the University of Pennsylvania. And finally, we'll close out with Matt Simmons, who is from Simtech Solutions. So I'll just say a little bit about the issues we're going to cover today. Of course, we're talking about why data collection is important, but beyond that, some real practical information about waivers, data sharing, data collection and usage, and mobile data collection tools that are available. Essentially, we put this webinar together because we understand that data collection is important at this time. There are several reasons for this. One is that it's useful in your public health planning, really the public health planning of your community, to be tracking sheltered and unsheltered people who are experiencing symptoms and who have been tested positive for COVID-19. It helps to do some planning about where to house people and to minimize the spread of the virus. We also recognize that data is useful when people are applying for public and private funding from all levels of government and private funders. The extent to which you can provide detailed data information and detailed information about how your community has been affected, that will help in any funding pursuits. Third, we know that as a community of providers who have been analyzing and considering racial disparities in our systems, that this particular crisis is exacerbating certain inequalities that have already existed, and we want to make sure that we continue to understand that and use that information to advance race equity goals. And finally, through these numbers, we can gather research that will help us for potential next waves of the COVID crisis, or similar happenings. And finally, as we go down the road, the things that you all are doing now are definitely informing best practices on how to quickly house people more generally. So with that table set that we wanted to provide, I'm going to shift into the conversation from Fran from HUD. Thank you, Fran.
Well, thank you so much for inviting me here today. I'm going to see if I can take the screen over. And talk to you. Is everyone able to see my screen?
No, not yet.
Okay. Let's see here. How are we doing now?
We can see the screen.
Excellent. Thank you so much. So I want to thank you all for having me on today. I'm excited to talk about what's going on with HUD and about our perspective around data collection and the use of the homeless management information systems for that. I just wanted to start off with kind of a brief overview around the CARES Act funding. So probably most of you are aware the CARES Act funding that's coming through the HUD Office of Special Needs Assistance Programs is $4 billion in emergency solution grant program funds. And for perspective, our largest program, which is the Continuum of Care program, is $2 billion. So this is a huge amount of money. And we're having this money go through our office really quickly. And so we've already announced the $1 billion of that money, and that announcements are on their website now. And then we will, over the course of 90 days, be doing the balance of the $3 billion. There's going to be information that's going to be coming out on our website about, it'll be a notice that explains more about the authorities for uses of that funding. Communities have a lot of questions about the Emergency Solutions Grant CARES Act funding, and so please bear with us as we get that information out to you. For COC and ESG program funds that are already in existence, we have waivers that are out there on very specific things that help communities to use that funding to respond to the coronavirus impact in our communities. We have regular office hours every week on Fridays. They're amazing, and I highly encourage you, if you have not attended, to attend. We also have them recorded, so if you have not been able to attend them, you can go to our website, and we have them recorded. I think there's probably 6 or 7 up there now. And you can go back and listen to them. And we have not only HUD staff talking about what HUD is doing, but we invite other federal partners to come on. We have the CDC on there regularly talking about what's happening. And we have, I think the last time we had the VA on talking about what's going on with the VA. So they're very informative. And they offer a Q&A, so community members can ask questions. So I think that's extremely helpful, and I would highly encourage you to join. I want to talk about a waiver that's very specific to HMIS, as you guys will probably be using HMIS to support data collection for COVID-19. And one of the things that it's doing is as this new money comes in through the Emergency Solution Grants Fund, typically what happens is only the HMIS lead, the agency that's designated as the HMIS lead in a community, can spend funding for specific things to support the HMIS software. And that other organizations that receive ESG or COC funding that have an HMIS line item, they can spend it on HMIS activities, but it's very, very narrow in scope. And so what this waiver does is it allows people that receive this funding to be able to use that funding for HMIS related costs that are much broader in scope, for doing enhancements to HMIS to support activities related to COVID-19. So you can read the waiver, and if you have any questions about that, you can submit an AAQ on the hudexchange.info website, and we can provide more information on that. I think overarchingly, the thing that's most important for HUD right now for us to communicate to folks is that, you know, we understand that your number one priority right now is the response to COVID-19, our number one priority. And so we are taking this into account in all the decisions that we're making, and we know that you're taking this into account in the decisions that you're making in your communities. So we will be thinking about this when we're thinking about in the future performance metrics, monitoring, governance, competition. And so, you know, we want you to be focused on what's important, making sure that your community is safe, the people that you're supporting are safe. And so it's totally appropriate to be focusing on those efforts right now and not to be worrying about performance metrics and all those other things. We will take those things into consideration down the line. So, and at the same time, we're also encouraging continuums of care to also have some flexibility when they're thinking about competition metrics. So just to, you know, this is creating a lot of stress both on our communities and on ourselves as we try to address this. So just think about those things that you want to prioritize in your community and what's most important right now. So I think this leads perfectly into a conversation about balance. So I have a lot of experience going back doing disaster response work and data collection. So I started doing data collection and disaster response going back to Hurricane Katrina in 2005. And so one of the things to think about is that when you have a disaster, whether it's this type of disaster or natural disaster, there are a lot of things that impact our ability to be successful. We have the level of effort that's required, the resources that we have available to us, the impact that we're experiencing changes over time. So you may have situations where you have, at the beginning of an event, you may have staff resources that look very different a month into an event. You may have funding that's available at one point in the time of an event that looks very different than a month later or 2 months later. So when you're thinking about data collection and your response and how you are going to develop a plan around data collection and a crisis response, you want to think about how do you create balance in understanding what is the critical need in the moment, but also what can you create success around? What is the minimum necessary to do the thing that is most important for your community to keep folks safe? As time goes by, you will be able to make adjustments, and we will learn as we go along. So, you know, we're seeing as this event extends out that the CDC is learning things and they're providing new information to us. So it is this is iterative, and what we knew early on, and week 2 and 3 is very different than week 4, and it's probably going to be very different than week 8 and 16. And how we make adjustments in our data collection, that will shift. So keep that in mind about being flexible and considering the scope of what you're doing. I have a couple bullets here around national data collection efforts and ESG. I just want to say quickly, HUD has touched base with all of the federal partners to ask if they have any specific COVID requests around data collection and HMIS. We believe that there's going to be very minimal, if any, requests for changes to HMIS. So we don't anticipate much of an impact there. There are communities that are implementing FEMA non-congregate shelter programs, and they are doing things locally. When communities make decisions about utilizing FEMA for non-congregate shelter, it's because they've received public assistance funds. That is not every community accesses public assistance funds through FEMA to do this kind of work, but some communities have, and so they're implementing those. Please be aware that there is an effort that has gone where we have supported California in implementing a process to use HMIS across the state. And we've put up some support materials, so if communities want to look at that and see what California is doing, they can. There's also some information that we put out in an office hours around what North Carolina is doing. That's available also for you to look at. I'm going to talk about data sharing, and then I'll wrap up, and we'll get to hear from Dan and Matt. So privacy. This one's really interesting. We put some information out on the HUD Exchange around privacy because we were getting a lot of questions about, you know, can I share with public health authorities? Yes, but there's caveats to that. So we wanted to put information out that would be helpful for communities to assess their privacy policies and be able to make decisions around this. So there's two things to understand. One is that HMIS are governed by the HMIS security and privacy standards. These are standards that date back to 2004. And there's a set of minimal standards. They actually follow HIPAA standards, and they're not extremely limiting. They actually allow for a lot of flexibility. Communities, however, have often layered on a lot of limitations in their privacy plans, you know, as they've made them appropriate for their local needs. However, the HUD standard does allow, it is permissible to share or disclose data there are several ways that you can actually do disclosures. And so there are two that are very specific to our situation that I think are helpful to understand. And we've put up some documents about that, but just really briefly, one is disclosures required by law. The other is disclosures to avert a serious threat to health or safety. And so you can see a description up here on those. So disclosure required by law. So legally, if you're required to do a disclosure, yes, you can do a disclosure. It is permissible by HUD for you to do that. And under the serious threat to health and safety, there's some caveats there. You have to believe that the person that you're actually making the disclosure to has the capacity to actually reduce the serious threat to health and safety. So there's some caveats to this, but yes, you can do some disclosures. There's also some limitations. So it's not that you're disclosing all of the records in HMIS. You want to make sure that you're disclosing things appropriately. So, you know, if a public health agency does not seek or require personal protected information, so maybe they don't need all of the person's personal information, then you wouldn't disclose that. Or maybe they don't need everyone's information, they're only looking for 5 particular individuals, then that's all that you would disclose. So you want to be very cautious about what you're disclosing and make sure that you understand what those limitations are. So you can read in more detail information on the HUD Exchange that lays out all of this information in a way it's too quick for me to go through them at this point and for you to get all of this information, but it's written out very well online and you'll be able to read through it, and you can also submit AAQs if you have further questions about it. The last thing I would say about this is that if a community's privacy notice is more limiting than HUD's, your privacy notice can be amended. It can be amended at any time, and the amendment is retroactive, but your amendment cannot be less restrictive than what is required by HUD. So those are some things to consider. You may also want to have a legal review of whatever you do to your privacy notice, but it must always meet the minimum privacy and security standards. This is the information where you can find out more about the privacy notice and the examples from North Carolina and California. If you go to the COVID-19 HMIS resource page, all of that information is in there. The top link is our kind of overarching link for all of HUD's infectious disease prevention and response information out of the SNAPS office. If you have any questions about what you heard today, you can go to that Ask a Question, submit a question. We're responding to those very quickly.
Thank you, Fran. So we are going to take a moment to shift screens, and Dan Treglia will be up next. So I guess, Fran, if you can, okay, thanks.
I think we got it.
Perfect.
You can all see my screen now? Fantastic. Hi, everyone. My name is Dan Treglia. I'm a researcher at the University of Pennsylvania. And I'm going to do two things. I'm going to kind of give an overview of what I'm seeing, and to some degree that's going to be systematic, and to some degree that's going to be anecdotal, because frankly a lot of it is based on anecdote and phone calls and things like that. And some of it is going to be kind of providing some resources that might be of use to you in a couple of domains. And then third is a plea for not just data, but you to use the tools that are available to you. Okay, so we'll start off with kind of understanding how surveying is happening of people that are experiencing homelessness, both people that are unsheltered and people that are that are entering shelter or are in shelter. The most common themes are around symptoms, but there are several other kind of topics and domains that have been explored in some of these surveys as well. And then thinking about the data collection side on the how are people being served, where are they going, and how are COVID-19 data being incorporated into HMIS, if at all, and kind of where and to what extent. Third, we'll get into kind of managing gaps in data exchanges and relationships between healthcare and homelessness systems. And I'll highlight a resource out of CSH, the Corporation for Supportive Housing, that's meant to fill that gap, and I think does a pretty good job. And then we'll talk a little bit about community responses, at least in terms of kind of what we know, but mostly kind of what we don't know, and some efforts underway to try to understand those a little bit more systematically. Okay, so what I have on the screen here are a couple of tools being used to try to assess COVID-19 symptoms among homeless adults. The one on the left is one used for people that are that are unsheltered, and the one for the right on the right is being used as a triage tool for people coming in to coordinated entry, and they're going to have kind of a lot of times the same questions, but very to some degree different purposes. You see they ask about different things, and I'm highlighting kind of two examples here. They ask about symptoms in very different levels of detail, and I've seen, I think, no fewer than 30 different surveys with different kinds of questions about symptomology. And I think there might be some resources kind of being developed to try to, there have been conversations about kind of standardizing some of them and getting a lot of them out and putting them in a central repository. I'd love to see that, because I think that can make these tools kind of more available and easier to use. Okay, and then the triage tool on the right side and the something not included in the screenshot on the left side is kind of triggers for action. So what can happen? So you can see on the right side, if a client answers yes to questions 1 through 4, they should be transported to the hospital for testing, right? Or if they answer yes to just questions 1 through 3, they should be masked and asked to isolate. Okay. One of the other domains that I'm seeing being asked about in surveys, but much less commonly, are the needs of people that are experiencing homelessness. So this came out of Human.NYC, which is an advocacy organization based out of New York, and they've been focused mostly on the unsheltered homeless population, and they've been asking about kind of current sleeping conditions, the resource gaps particularly not just existing resource gaps, which they've been highlighting throughout their work, but new ones about ability to shower, ability to get food now that some of those options have closed down, along with limitations in access to hygiene supplies. And they've also been working a little bit with the City of New York's Department of Homeless Services to provide, I think, a couple of things. And so just checking in with people to see whether or not they've had contact with mainstream service providers and what their outcomes have been through those avenues as well. Again, that's a very different domain. Here's a third one, and this is more applicable to some areas than others. And you're going to see this again when Matt Simmons gives his presentation. But this is understanding the conditions that are taking place within an encampment. So this is less about kind of an individual's condition. It is less about the resources that someone has availed themselves of or has been available to an individual. But it's about kind of, are they in a place in which they kind of can continue to live safely and receive the resources that they need. So it asks about, and I'll just go through this at a very high level, right, the conditions of the encampment, the ability for people to social distance, which is very important and I don't think is being asked enough of these surveys. And finally, and echoing the human.nyc survey, the need for additional facilities and resources. And you can see that in question 14 on the bottom. Okay. There's an obvious role for mobile technology here. Okay. And that works in two different ways. One is that surveys can be distributed through SMS to the extent that HMIS and homeless service providers are collecting people's phone numbers. And obviously to the extent to which those phone numbers remain constant over time, or at least relatively recent, kind of relatively brief surveys to check on someone's status could go out to kind of people that are known to be experiencing homelessness. And that's obviously particularly important for people that are living unsheltered, and even more so for people that are living not in encampments, more in a place like New York, where people are kind of one person here, one person there, as opposed to someplace maybe like a Los Angeles, where people are somewhat more likely to be in encampments, and one trip to a single encampment can have better kind of returns and better scale for data collection. But obviously, this tool could also be used in the health screening info, which again Matt will talk about, can be used by outreach providers on their own or system provided handheld devices, and when integrated with other systems, could allow for direct triage and entry into HMIS. And I'm seeing that happen sporadically, and generally that's true of outreach generally, right? There are some handheld systems, I can't name off the top of my head, that are kind of separate, exist in a separate system. Philadelphia is one, and then there are others that are integrated into a central database. Okay, so moving into collecting data in HMIS. So again, some HMIS vendors and leads have been creating their own tools. There is, as yet, you can see they generally ask about symptoms and testing, when was someone tested. Some others go into when was someone isolated or moved into an isolation shelter, have they returned, but that seems to vary from provider to provider, from vendor to vendor. And it is unclear at this point the extent to which those data are actually being entered. Right, I know that they're being put into systems and made available. I'm curious. So one thing that I would like to find out from this group, and there are, last I checked, about 640 of you here, are kind of, to what extent are you seeing these tools? Are you using these tools? How are they helpful? How are they not? Because it's important that we want the information to kind of understand how COVID-19 has spread among the homeless population, and how people are moving within systems. But obviously, that is secondary to making sure that you can provide the services that you need to provide. If you want to make sure that those work harmoniously. We've also gotten, one thing that I've heard is that providers have some level of discomfort about asking health-related questions, because many of these systems are not. Many of the people that are asking these questions are not used to asking health-specific questions and diagnostic-specific questions, and it's not a domain in which they feel comfortable probing. But one kind of reason I would argue that you should be entering some level of data, and I know that those HMIS data tools have been put out at various points, right? Some were put out, 3.5 weeks ago, and some tools have been refined and put out more recently since then. But I think it's still very important and very helpful to capture data on some basic level. So on the right is a dashboard that was created is a screenshot of a dashboard created by WellSky, and this can be used in the same way that you can use these kinds of dashboards and tools on a regular basis to understand changes in your systems, to understand trajectories, and there is an obvious and urgent advocacy need here, and to the extent that these tools can be used to show an urgent need, and these graphs can be taken and put in front of policymakers and organizational executives who can then go and lobby and testify. Those tools might be very, very helpful. Okay. That said, part of what we're also hearing about is that there are disconnects between systems. And particularly I'm talking about isolation sites where people that have been kind of screened positive, either through a positive test or by showing symptoms, go to an isolation site. And my impression is that those are the extent to which people that enter those systems or those shelters are actually recorded in HMIS is inconsistent. And sometimes it depends on the locality. So there are some places where there is a complete wall and someone might have been referred from the shelter system to the isolation site, and then they come back, but that period when they're in the isolation site is just going to be a gap. It's going to look like an exit. And then there'd be some places where people are coming in through different systems. Right. So I think it's New York, where if you come in through the shelter system, you're in HMIS, but if you're not recognized by the shelter system prior to that incident, you go through a different shelter system. You go through a different system, and you're not going to be recorded in HMIS. And these are also limitations that we need to be aware of, and context that we need to have when we're looking at data. We want to know, are we missing people? Aren't we missing people? And that's going to require an additional level of coordination. And we all know that all of this requires almost inhuman levels of coordination to begin with, to try to get these data, and then to understand kind of this level is going to be just additional work, but it's going to be helpful in understanding the dynamics that we're seeing. Okay. So this is another place where kind of real-time data matches between healthcare systems and homelessness systems can be important, especially for coordinating services and medication, and also for understanding prevalence. So maybe there's not going to a caseworker, but to the extent that we can understand who shows up in a shelter system, tested positive, 2 days ago, 3 days ago. That's always helpful to know, and can help providers provide better care to the people that are in their shelters. But that's, again, not happening nationally. And so the tool on the right here is a tool from CSH, which is the COVID-19 Resident Self-Advocacy Form. And I think this was often used for people, or it is theoretically designed for people that are in supportive housing, but can certainly apply to people that are in shelters as well. And it's a tool where symptoms can be recorded, testing can be recorded, and medications can be recorded. And a client can bring that piece of paper kind of with them from a shelter to the doctor's office, to the hospital, and then bring it back to their caseworker. And that can, it's not perfect coordination, it's not perfect automation, but it can certainly help to close some gaps in the meantime, especially when staffing levels are, lower than they usually are, and the need for coordination is higher. Okay. Next, moving quickly into how are communities responding to this crisis. And the fact of the matter is, we're not terribly sure. Like in a systematic perspective, we're not terribly sure. I don't mean to be glib, right? I think the information that I'm gathering and when I'm hearing that others are gathering that are much smarter than me is that it's occurring through kind of phone calls and emails. And so we don't have a better handle on kind of what our communities doing, which ones are providing hotel rooms, which ones are creating isolation sites, and how are they going about doing that. And that's something that will obviously be helpful because we're all in uncharted territory here, right? Whether it's, you know, New York or Los Angeles or Polk County, Iowa. And so it's really important that we kind of get that information and share those best practices. So plug number one is NAEH is putting together a survey that will be going out via email, I believe, to continuums of care, asking them about how they've been responding to this crisis. Please fill it out. It's not going to have that many questions. Its goal is certainly not to be onerous, but to provide kind of critical pieces of information that can help us aggregate data and understand this at a pretty high level. CSH is trying to do a nice job here of understanding what's happening at the organizational level or at the program level. And I have the link for this tool as well as the link. I have the link for this tool on the slide, and the link for the other tool is on that slide as well. This is their budget and expense tracker, and this is a place where organizations can record their personnel and non-personnel costs that are related to COVID-19, and that allows them to kind of just document the impact, because this is going to be a question we're going to want to know later, is what was the impact, financial and otherwise, and to the extent that organizations can be reimbursed for their COVID-19 related expenses. This is a way to systematize it. This way you're not, you know, digging for receipts for non-personnel costs later on. Okay. Lastly, we created a tool. Tom Byrne at Boston University created this dashboard that is meant to be used as a rough kind of planning and response guide. So some of you might have seen the paper where we put out kind of, here's additional capacity on a continuum of care basis that we think you're going to need, and there are certain, you know, assumptions that are built into that. But obviously those are assumptions. Those are assumptions that were made, you know, in mid to late March. So A, things have changed since then, and B, they're not catered to every locality. So this gives you the opportunity to take your PIT data from 2019 and toggle with the infection rates, your unsheltered numbers, what proportion of your population are at high risk for COVID-19 complications, and your annual shelter turnover, and it'll provide capacity needs by COVID-19 positive or negative status, and your risk status, and someone's risk status as well. And this is plug number two. This is something that we built this dashboard, and we built the data that are in that report out of data from two cities, the age distributions in New York and Los Angeles. But I think it goes without saying that A, things have changed since we last collected that data, and B, New York and LA are not exactly representative of the country as a whole. And maybe from an age distribution perspective, they are, but certainly in some other ways they're not. And so we would love to I'd love to talk with you about trying to get that information, that age, race, and sex information from kind of about your shelter systems, so that maybe we can A, kind of update our data, and B, and update these models, B, make them kind of more tailored to your locality's needs. I have my contact information here. I'm sure it's also somewhere else on the site. And with that, I will flip it to Matt.
All right.
And I'll just mention really briefly, if you have any questions, please do enter them in the Q&A section at the bottom of the screen. And I think Matt is almost ready. Okay.
All right, we're good to go?
Yes.
All right, excellent. I'm Matt Simmons from SimTech Solutions. And let me just went a little far. Our company provides mobile technologies for point in time and outreach. There's some examples here on the screen. You know, in Gulfport, they're actually using the tech in order to maintain a by name list, so they know who's out there on the streets on any given day, and keep tabs on people. And then for the point in time, we had 43 communities last year using our technology of different sizes as far as the communities go. And it's geospatial custom surveys. So, you know, can do the point in time, but they can also answer region-specific questions as well. And where this is going is we can actually use the same technology potentially for the COVID outbreak and some health and wellness screening for that. So the technology, GPS enabled, allows for real-time data collection, and it's conditional logic, so the surveys themselves are customized to the person being surveyed. So for example, you're not going to ask a 12-year-old child if he or she is a veteran. You don't ask a male if he's pregnant. The geospatial reporting on the back end really helps us slice and dice. In this case, I'm showing San Diego County, but if you know, a mayor of Escondido, for example, wanted to know what's going on locally, they can get results within that particular city or town without having to see the noise for all the towns around them. Beyond that, we, you know, over the years, we've built out additional functionality to support account, so account team management functions in order to make sure your accounts are properly staffed, volunteer registration portals to get the volunteers in, setting quotas, and then being able to generate the reports to go back to Fran and her crew at HUD. So details are there at point-in-time.info, but in general, this is what's called a heat map, and what you're seeing is the results of the 2020 count. You know, by using a heat map, we can obfuscate the actual survey locations, but you can see that there's concentrations here in Oceanside, Escondido, and definitely down here in San Diego. Now, with this information, we were able to hand over the actual survey locations. There was over 2,100 volunteers that participated in the count. The results aren't final, so I'm not showing that right now, but you know, once the county had access to this information, they were able to place 66 hand washing stations. The numbers, I think, is closer to 300 now as far as hand washing stations out in the community. But they're able to use the GPS coordinates from the point in time information to figure out where to properly place those hand washing stations so they're going to get the most impact. So using GIS data and geospatial reporting to curb outbreaks. So because it's mobile-based technology, when you conduct a survey, it captures the date, the time, and the location, as well as the information about the surveyor. So, you know, if we were to go down the path of patient zero reporting, so patient zero reporting, what I'm referring to here is similar to like Typhoid Mary, you know, going back in history, where if you could figure out who that patient zero is and who he or she came in contact with, you can follow that chain down to see, okay, you know, here's, you know, this person one came in contact with these 3 people. And if you go follow them and find out if they're testing positive or negative, if they're symptomatic, you can basically keep repeating that exercise to close those you know, certain people off and say, okay, we've confirmed that they are negative, so we don't have to keep going down this path. But you're able to do that with if you have enough data, and that's part of the issue is capturing enough data to complete that picture. So that's something to keep in mind. But the idea also is to be able to follow up and monitor people that you don't always see. So, you know, with the shelters, they're going to come back every day, ideally, and you'll get a chance to see them. But on the streets, that doesn't happen. And we want to be able to engage people and serve them where they are. Don't necessarily have to have them come down to a centralized location. You're trying to reduce mobility wherever possible, and just check in on people. And then by implementing a health and wellness screening tool, if we need to quarantine people or isolate them, so either the first people under investigation, or they're known to be COVID positive, or they're highly vulnerable, high risk, then we have to think about where to put people that makes the most sense. So having these tools, the idea is to help support those actions. And so basically the triage process that we're seeing, it does require housing and shelter options to separate people as needed. And it requires a screening mechanism to help guide that triage process. So the diagram over to the right is a sample flow diagram that was put off by the USC Benioff Homeless and Housing Initiative and Margot Kushel. So if you can see here how it flows, you have it's basically the current status of people, whether they're in the shelter, in medical care, or they're unsheltered. And you're going to be looking to see if they're a person under investigation, so they're symptomatic, or they're COVID positive, where they might flow to. If they're COVID negative, but they might be at high risk, they also might have a separate placement. So you may be looking at isolation units for people that are high risk, but again, presumed COVID negative. So in general, the idea is to separate people that are COVID positive away from others. People that are high risk, separate them from people that are COVID positive. And then you have a general population, you want to decongregate wherever possible and spread people out to minimize the risk of infection. So in order to identify the vulnerable or high risk populations, what we've done within our command center, which can be done within HMIS, any data warehouse you might have access to, is think about really what it means to be high risk. And in this case, we're filtering by age range and chronic health condition. So you're looking for seniors with a chronic health condition. In the Venn diagram, if you have both, if you're a senior with a chronic health condition, those people should be prioritized at the top. And then if you only have one of those, then should be next in line, and then neither should be towards the bottom. So if you have hotel units available, for example, in Boston, they're using dorm rooms, you might be able to say, okay, we need a prioritized by name list and what accorded entry, but you're changing your prioritization model to really focus on age and chronic health conditions. So health and wellness screening, Dan shared some examples of what that might be. We looked at guidance that came from CDC, and all these are links, by the way. So when we share the slides, you can get those. You can also get them from ourselves, and they're also, you can just Google these and you'll be able to find them up online. So interim guidance for people experiencing homelessness from the CDC. There's COVID-19 HMIS setup and data sharing practices from HUD that should help answer some of those questions too about data sharing. So I highly recommend reviewing that if you haven't. And then there was an initial tool that was put out in Atlanta, Georgia, as a client triage tool that we reviewed. Here locally, I'm in San Diego. We shared a Word version of the tools before we code anything, and with different medical professionals, we had them weigh in using track changes, a simple, comments and track changes back and forth. We basically kept refining with their feedback. And then in addition, we created a simple Google survey form. We shared that online with social media, with our peers, and said, here's our tools, here's the survey we're thinking about implementing, let us know your feedback. So we gathered it all, and we're able to create the surveys we have now. If you're interested in checking them out on your own, the app is called Counting Us. You can download that from the App Store, Google Play, and then after you register an account, you just type in the setup key of Stay Healthy. That's the idea here, and you'll be able to see the surveys. And beyond that, we're actually offering the tech for free. It's partially in honor and in support of a friend of mine, Andrew Barrett, who is actually in the ventilator right now, recovering, but also because we know so many people out there don't have the same protections that we do. So we're offering that tech for free for 6 months, and we had to put something down there. We're not going to pull the plug. We're extending this offer to as many people as we can with the resources that we have, which are limited. But we know that some communities are struggling with how to rapidly deploy something to help the people in need. So, we're offering in good faith, as is. Again, the surveys are based on what we know, and we're all learning. As Fran said, this is a learn as we go model. So there is nothing that we can say, this is going to work 100%. All it is this is what we have, and we want to have it help as many people as we can. So that offer is out there, and we're serious. We'll a $0 contract, have all the data sharing pieces in there, and we'd be happy to talk it through if there's any questions locally on that piece. The assessments themselves, again, is a full assessment, which is a little bit more detailed. It gets into some of the where are you sleeping questions, some of the more details about a placement. For example, if someone has a pet or a partner, those kinds of information you might want to tease out, things that you're familiar with coordinated entry. And and then a briefer version, which is what's shown here, which Dan already shared with you. So really high level on under the COVID, basic demographics. We do have veteran status here in the sense if you do have VA specific resources to stand up, that might be helpful. And then contact information. So the idea of helping someone using virtual case management, getting back in touch with the person, that really is critical. And you'd be surprised how many people living on the streets actually do have a smartphone because it's one of the last things people tend to get rid of. And there is also financial supports for the phone. On encampments, the CDC actually published some guidance on encampments. I'm not going to read through it all, but the key section right here, if toilets or hand washing facilities are not available nearby, provide access to portable routines for encampments of more than 10 people. That's a big part of it. And then the other side of it is don't clear the encampments. If you're doing that and you have that practice, traditionally, this is not the time to do that. There might you have to move people along, but you're trying to reduce mobility wherever possible. So, I have seen communities stand up sanctioned encampments. King County is doing that, and they have sanctioned encampments. And if you're to bring people together, that's great, because then it's one place for you to go. Now, don't bring them too close together, but bring them to one general space where there is still isolation involved. But if you need to bring in showers, you need to bring in laundry facilities, et cetera, you have one place to go to do that. So the CDC guidance is here. And in support of that guidance, again, there's an idea of an encampment screening tool. So again, this is all the guidance that we use to shape this screening tool. Could you add it to HMIS is one of the questions. Absolutely. One of the things that you are missing though in HMIS is a project type to associate this with. So that might be a question back for HUD. I'm not going to put Fran on the spot, but the idea of a sanctioned encampment as a project type might be a consideration, because then you'd have something to attach this to. And then when it comes time for patient zero reporting, anyone that's at that same sanctioned encampment at a given day, you could do follow-up on that. So something to consider and postulate. I'm not saying this is how everyone should do it, but thinking it through internally, that's something that we'd look to do.
Okay. Oh, sorry, Matt.
No worries.
I thought you.
So along those lines, you're gonna, with encampments, you have outreach teams, ideally, and you have outreach teams dedicated to certain encampments and to certain locations. Here I'm showing a map that allows you to, within the command center, define what your coverage areas are and then go ahead and assign those to encampments. This is the kind of the virtues of GPS-enabled technologies, but so just for that piece. And moving on, some of the refinements you might have in a command center kind of environment or HMIS is if you are going to add questions like in HMIS as an assessment, for example, have you had cold or flu-like symptoms within X number of days? Yes, currently experiencing. If you're going to subset your by name list, you might look to add custom filters in order to work that list down. And so what you ask, obviously the questions you ask are going to be based on local circumstances. For example, if thermometers are not available, then you're not going to ask for an actual temperature. You'll ask if someone has a fever. And this is a design practice called tagging, assigning response tags. If you're, whether or not your system can do this, the command center that we work with for the point in time and for this response does. But feel free to steal from our ideas on this. The idea is surveys can be assigned multiple tags, and then you can filter and slice and dice them as needed in order to help manage that list over time. And then the other side of this, with this COVID-specific enhancement, is you're going to have multiple surveys for the same person, ideally over time, because you're going to be following up with that person. So we need to be able to link those together. So in this case, we're using Amazon Glue. Amazon has actually been kindly supported some of this initial work, which allows us to help offer this tech for free. And in this case, we're identifying duplicates. So I've hidden the names here. And are these the same record? If they are, then we can stitch them together to create a single client longitudinal picture over time, showing their locations and their health status over time. And here's my contact information. More information about the tech in general is here. If you are interested in using this, this is a simple email, helpdesk@fintechsolutions.com. We'll get you set up. We'll send you a draft conduct agreement and answer any questions you have. That's it.
Okay. So I guess that pause is the end of your presentation. Yeah. Sorry about interrupting you. I thought you were finished with your comments. So I'm going to move into a couple of the questions that we have here. There's a category of questions that are particularly related to privacy concerns. So one person specifically raised a question about HIPAA. Another, I'll read the question from Anonymous. Is anyone worried about client privacy? Entering personal health information into a non-medical database concerns me. Would we want our COVID-19 status entered into the database? I understand gathering information as people enter programs. I'm concerned about entering it into a database. So I'll see if anyone from our panel is wanting to answer some of these concerns.
I'm happy to take a first pass at that. To be a HIPAA covered entity is something very specific. So most homeless service providers are not HIPAA covered entities. The actual collection and entering of health data into HMIS does not make you a HIPAA covered entity. However, the HMIS privacy and security standards are aligned to HIPAA. So, if you were following those standards, you are essentially following along with a lot of the primary things that you would follow in HIPAA. So you're not really out of alignment with those. And we are concerned about client privacy. That's why the privacy and security standards exist, and they're important for communities to understand. That's why you do need to have a privacy notice. You need to be really clear about how you manage data in your HMIS. The individuals that you are collecting health information from and putting it into HMIS, they should understand what is happening with their information and be able to have access to that privacy notice. And your provider should be able to explain what is happening. So there is a level of responsibility around collecting health information and around disclosing information. So it's not that there's not a concern. It is that with the proper privacy practices and understanding of how to protect that information, HMIS can be a very appropriate and the kind of a good place to manage that information, as long as you have good privacy notice in place and people are well educated.
Okay. A question for Dr. Treglia. Denise is wondering if you're seeing data being collected from different types of communities. She uses the example of New York City and LA. New York City because it has a lot of shelter, in LA because they have a lot of people who are unsheltered, just as an example of diverse types of communities.
Sure. So in terms of the data that we see are being collected, so every place is collecting data but differently, and I'll admit that I don't have a great handle on what's happening in LA. I think data are being collected rather broadly, whether or not that's being kind of linked to an individual or just a survey, and whether that's being linked into HMIS is what's varying. So in New York City, data are being entered into their database. But I know that that's occurring, and like I said, I think the people that are registered with the shelter system, when they're going to isolation sites, I believe that is being included in HMIS, right? It's coded as a type of facility, and they're moving over there. and that's great. But I don't think that's universal. So I think there's data collection happening pretty universally, but I think it's a hodgepodge of exactly how it's being collected and what's being collected.
So there seems to be another category of questions about ways that funds can be spent. So Matt had mentioned hand washing stations. There may be needs related to adjusting HMIS to do this work. People need the cell phones and service so that they can keep in contact and find out about housing. Are these types of items eligible for ESG funding? I guess this is a Fran question.
I can speak to the HMIS piece of it and say that, yes, and I would coordinate with the HMIS lead in your community, but yes, with the waiver, anything that is an eligible activity that the HMIS lead would pay for, which includes equipment, you then would be able to use the ESG funds under the waiver for that type of equipment, which can then also include connectivity. So yes, on equipment to do data collection and internet connectivity, both of those. As far as cell phones and hand washing stations, I don't have that at I don't know that right offhand. But there is a notice that's going to be produced that's going to have what are going to be the authorities under the notice that's going to be more descriptive about what can be done under the ESG COVID funding, under the CARES Act funding. And so then I think you'll have more answers around that.
Okay.
So I obviously can't offer any more insight than Fran on that, but what I can say is there are lots of organizations that are kind of doing those things anyway, and if you're doing them, use some sort of tool, and that CSH tool is a fantastic one, so that if it is a reimbursable expense, you have it recorded in a tool for later, and also because if many entities across the country are using a single tool, that's going to make it much easier to reconcile everything later on.
Okay. An additional question from Anonymous. Should the encampment surveys be in HMIS? I think, Matt, did you indicate you wanted to?
Yeah, I verbally addressed that a little bit. I think it really depends on the encampment too, as well as if it's sizable, that it would make sense to consider doing that. There isn't really a project type right now that's set up for encampments. That's the one, the caveat I have there. So if you can map it back to street outreach, I think that would probably be of value for your HUD reporting. So it would really be up to your vendor. The need I could see being there, especially if you're adding, keep in mind the encampment survey is more like the program descriptor data elements for a shelter, in that it's an attribute about an entity, not a person. So just being clear there too. So it really is up to your vendor what they can handle. But I do see value, whether it's in HMIS or separately, to be capturing details about your primary encampments, just so you have a roster of here's where they are, here's what they have, and here's what they need.
So there's another question here about collecting data and being a little apprehensive about doing that because of how the staff will interpret that data. Any words of advice on that? The concern is that staff will want to diagnose people, perhaps treat people differently because of that. Any insights there?
I mean, I think this, I don't know if anyone else on the panel wants to talk about this, but whenever you're doing an assessment, this kind of goes to thinking about coordinated entry in general. When you're doing an assessment and you're asking a series of questions, there's always this piece of what do we do with these questions? How do we handle asking individuals questions, especially when they're sensitive questions? And so I think a lot of it is about how does a program educate staff in how to ask questions, and then how do you manage the information that you receive? What do you do with that? So I think it's a lot about education, and what are the expectations, what expectations does the community have for its providers? So what is the COC doing to help kind of lift up expectations for providers about how we handle that? Because we certainly don't want people that are not health providers diagnosing anyone, but it's obviously very important to know if somebody is symptomatic to be able to make sure that they can get the assistance they need. So there's a balancing act there. So what do we do with that? So I think that there's some important information that we can gather through the CDC and all of the rich information that we're getting about what kind of assessments we can do, what kind of questions we can ask. And then it's about educating around, you know, where are the lines, where are the boundaries around asking questions, getting people the right information, but not crossing boundaries.
Yeah, agreed. To take that one step further, I also think it's important for communities to have a triage protocol. And so California, the diagram that I shared, there's a paper, you know, instructions of if this happens, then do that. And so it takes some of the decision making away from frontline staff. It makes it easier if there's a protocol in place.
Okay.
Yeah, I think I would really underscore what you just said. I think that, you know, frontline staff really want to feel supported, and that they know what to do. I mean, they don't want to be left not knowing what to do in a situation. So I think having that kind of support is really helpful.
Yeah, and just one more thing on that. Obviously, your options are going to be limited if you don't have, you know, alternate places for people to go. So if you're still business as usual and it's just your shelter system, then why are you going through all this? Because you're just going to put people right back to where they started. You know, it's really important to stand up those resources. There are funding sources available from FEMA. I think there's other additional funding that's available through ESG in order to get some of those isolation units or quarantine units. And then also encouraging, when people don't want to receive services, don't sweep the encampments, but give them what they need to stay where they are.
And I'm just going to do one last question. Another anonymous wanted you all to dig a little more deeply into the issue of you're collecting the data, you're urging people to collect data, but how are communities actually using this information, and how are they using it for their planning? Can you provide a little more insight into that?
Sure. I mean, I think it's happening in a couple of ways. I mean, we've heard that people are looking to that tool that I have in there as a way of thinking, kind of in broad terms, right? It's not a locality specific tool, but in broad terms about what kind of capacity they need, because, you know, we talk about that in other places, and there are lots of other people talking about that. But in terms of how much capacity they might need, they're using that tool to plan for the next, you know, few months or so. So we are getting some reports that the data are actually being used, and it's one of the reasons we actually want to kind of refine those models. Is it's more valuable with updated data and kind of broad data than it is just from 2 U.S. cities. But right, I'm also hearing, and Matt alluded to this with the encampment survey, that it's being used to identify kind of what resources are needed at a given point, and that same thing is true for that human.nyc survey, right? Kind of how useful it is depends on kind of primarily, or certainly kind of key, like what questions are you asking? And if you're asking just symptoms questions, you can do you can do some triage, you can do some screening, but certainly one of the things that we've learned from Boston and lots of other places is that is good, but has limited utility. But if you're asking about service needs and ability to stay in place, which might be the best kind of social distancing that they can get, right? We're hearing plenty of reports of those data actually being put into practice on the ground. And then the hope is as we, from that NEH survey and some others, is that if we can systematize that and understand how communities are responding, and combine that with probably more qualitative data about kind of where are people actually able to stay in place, where are COVID-19 outbreaks happening versus not, we might be able to understand kind of what's working and what isn't, and how we can kind of improve data collection for the next crisis.
And I would say, one of the things that HUD didn't do was rush to put out a set of data elements for folks to collect, because we really feel like it's important for communities to determine what is the local need that they have, and to scale that need. What is useful in California may not be applicable in Phoenix. Or what's happening in DC may not be helpful for Houston. So I think that, you want to see what's happening locally and determine, is health information that we gather, what would be the purpose for us? How does it help us serve the individuals that we have in our shelters? And start from that perspective. There's starting to become several tools that are available that you can look at and see, do they make sense for us given the needs that we're seeing? Some folks are using assessments to determine, is somebody symptomatic? Do I need to think about moving them into a space, creating separation? Who needs to be referred to a healthcare facility? So there can be different purposes. And so for each community, they need to determine, how am I using this information? How is it important for us? And then making the decision about the data collection. So HUD has not put any requirements around what that looks like. We are putting out guidance about how to be thinking about these things, how to think about privacy and security under this circumstance, and then also working with our federal partners to see, does there need to be any adjustments made, and then how do we minimize the impact on communities? So really pushing down the ability for local communities to make decisions around these things.
Well, I want to thank our speakers for joining us for this session today. And I also want to thank everyone who joined us online. A couple of remaining questions are related to materials. You will be able to find a recording of this webinar on our website, along with the PowerPoint presentations, which includes the links to the materials that speakers mentioned and their contact information. So if you are interested in following up on that, please refer to our website, and you'll be able to find that information, in addition to information about other webinars that we are planning and that have already held. Thank you, and thanks again, and have a good afternoon.
All right. Bye, everyone.
Thank you, everyone.
Bye.
Take care, everyone.